Okay, good afternoon to everyone. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our weekly webinar series entitled The Medical and Public Health Considerations of COVID-19 Vaccine Implementation. Next slide. The previous webinars are available and on demand at our website, acp.net/COVID-19 web. And this webinar today will also be recorded and will be available for broadcast starting on Friday, and all the registrants today will get an email about that on Friday. Next slide. There will be a QA at the end of the webinar. We usually leave about 15 to 20 minutes for the QA. So please type in your questions into the Q&A function during the webinar, either through the Zoom or on YouTube, and we'll get to as many questions as we can at the end of the talk. Next slide. We also have developed a series of FAQs on our various webinars, and these can also be found at our website. Next slide. Our speaker does not have any conflicts of interest to disclose. Next slide. This is a slide from the New York Times today, January 6, 2021. We're in the midst of the pandemic as it continues to escalate, and there could be no more an important topic to discuss than vaccines. Currently, we're having up to 250,000 new cases in the US each day, and numbers of deaths are in the stratosphere, approaching 4,000 deaths a day. Next slide. We're fortunate enough to also bring on as our guest moderator, Dr. Paul Dargan, who will be talking a little bit about the UK experience, both with immunization as well as a brief update about the new mutation that's been described at the beginning in the UK. Next slide. I'd like to introduce my co-moderator, Dr. Ziad Kazi, who's board member of the American College of Medical Toxicology and president of the Middle East and North African Clinical Toxicology Association and associate professor of emergency medicine at Emory University. He'll be helping out with the QA. Next slide. And then Dr. Dargan as well. He's a professor of clinical toxicology at King's College London and consultant physician clinical toxicologist at Guy's and St. Thomas's NHS Foundation in London, and I'll be providing an update from the UK. Next slide. At this point, I'd like to turn it over to Dr. Kazi to introduce our speaker today.
Thank you, Dr. Wax. It's my pleasure to introduce Dr. Satish Pillai, Senior Liaison to Operation Warp Speed COVID-19 Vaccine Task Force. Dr. Pillai is also the Deputy Director of the Division of Preparedness and Emerging Infections at the National Center for Emerging and Zoonotic Infectious Diseases at the US CDC. I've had the pleasure of working with Dr. Pillai almost a decade ago on a different type of emergency that related to radiation. And I was really impressed by his all hazards preparedness approach. And it's a delight to see him today playing this important role in our fight against this pandemic. And I look forward to his presentation. Dr. Pillai.
Thank you so much, Kazi. And thank you to Paul, and thank you all for the opportunity to speak to you a little bit about Operation Warp Speed and CDC and US government's COVID-19 vaccine implementation. Next slide, please. So I'll just start by January 4th, and actually these data are now being updated daily. CDC is posted and administered on our COVID-19 vaccine landing pages. Just today as well, over 4.5 million doses of vaccine have been administered. Considering that the Food and Drug Administration emergency use authorization was first issued about 17 days ago, it's rather remarkable to see that we have already begun vaccinations and reached this many Americans, and we're hopeful that these numbers will continue to increase at an increasing number or increasing rate in the coming weeks. Next slide, please. This graphic simply is to kind of represent that increasing kind of path of vaccination rates. increasing rate of vaccine, initially limited numbers of vaccine products. We have 2. We anticipate with additional clinical trial data, potential additional vaccines coming online, and there's also production of the existing vaccines, and numbers increase. The phases will move from phase 1A, which is healthcare providers and long-term care facility residents, to phase 1B, which are older Americans, 75 and older, and frontline essential workers, and then moving into 1C, which is individuals 65 to 74 and persons aged 16 to 64 with high-risk medical conditions and other essential workers. Subsequently, we anticipate in phase 2 of our vaccine campaign reaching the general public. When we have sufficient supplies to meet demand and supply, we will increase our access to vaccine to multiple points of administration, ideally including pharmacies, clinician offices, and other points of administration. Next slide. And next slide, please. Given your patient populations may have questions about mRNA vaccines, just briefly, like all vaccines, COVID-19 mRNA vaccines are being rigorously evaluated through clinical trials, and before FDA has issued emergency authorizations, they have had safety data monitored as well. While mRNA technology is new, it's not unknown, and they've been studied for over a decade. mRNA vaccines do not contain live virus and do not carry a risk of causing disease in the vaccinated person. mRNA never enters the cell nucleus and doesn't affect or interact with the person's DNA. Next slide. Two mRNA COVID-19 vaccines are currently authorized under emergency use. The Pfizer and Mrna vaccines. Both vaccines have demonstrated high and
So I believe we were at the mRNA COVID-19 vaccines. Both vaccines have also demonstrated an acceptable safety profile, though are fairly reactogenic, particularly after the second dose. Next slide, please. The ACIP has recently issued interim recommendations for the use of both vaccines for the prevention of COVID-19 in the United States. While the goal is to offer vaccines to every person who wishes to receive it, ACIP provides recommendations for the phased allocation of COVID-19 vaccine during the initial period of vaccine supply limitations. The Pfizer vaccine is authorized for persons aged 16 and older, while Moderna is authorized for those 18 and older. Both vaccine series consist of a 2-dose administration intramuscularly. The Pfizer vaccine is a 3-week apart series, while Moderna is the 2 vaccines are 4 weeks apart. Either vaccine series may be used. However, they're not interchangeable with each other or other COVID-19 vaccine products. So the same vaccine product must be used for both doses. And mRNA vaccines should be administered alone with a minimum interval of 14 days before or after administration with any other vaccines, which is an important point as we consider concomitant administration during flu season and ensuring that we have appropriate windows between the administration of these vaccines. Next slide, please. Next, I'll review the consideration for vaccination of persons with prior SARS-CoV-2 infection or exposure. Data from clinical trials suggest that mRNA vaccines are safe in persons with evidence of prior SARS-CoV-2 infection. Vaccination should be offered to persons regardless of history of prior symptomatic or asymptomatic SARS-CoV-2 infection. And viral nor serologic testing to assess for prior acute or prior infection is not recommended for the purpose of vaccine decision making. Next slide. Regarding persons with known current SARS-CoV-2 infection, vaccine should be deferred until the person is recovered from the acute illness if the person had symptoms and criteria have been met for them to discontinue isolation. While there's otherwise no recommended minimum interval between infection and vaccine, current evidence suggests that the reinfection period is uncommon for at least 90 days after the initial infection. Thus, persons with documented acute SARS-CoV-2 infection in the preceding 90 days may delay vaccine until near the end of this period, if desired. Next slide. Amongst persons in the community or outpatient setting who have had known COVID-19 exposures, these individuals shouldn't seek vaccination until their quarantine period has ended to potentially avoid exposing healthcare personnel or other persons to SARS-CoV-2 during the vaccine visit. However, for persons residing in congregate healthcare settings, such as long-term care facilities, where exposure and transmission of SARS-CoV-2 can occur repeatedly and for long periods of time, residents with a known COVID-19 exposure may be vaccinated. And in these settings, healthcare personnel are already in close contact with the residents, for example, by entering the patient's room for evaluation and treatment, and should employ appropriate infection prevention and control procedures when administering COVID-19 vaccine. Residents of other congregate settings, such as correctional facilities or homeless shelters with known COVID-19 exposure may also be vaccinated in order to avoid delays and missed opportunities for vaccination, given the increased risk of outbreaks in these settings. However, where feasible, precautions should be taken to limit mixing of these individuals with other residents or staff, except those essential for provision of vaccine services, and who should be employing appropriate infection prevention control procedures. Next slide, please. Next, I'd like to review vaccinations in special populations. Next slide. mRNA COVID-19 vaccines may be administered to persons with underlying medical conditions who have no contraindications to vaccination. Clinical trials demonstrate similar safety and efficacy profiles in persons with certain underlying medical conditions, including those that place them at increased risk for severe COVID-19 disease compared to persons without comorbidities. The CDC home COVID-19 landing pages have a list of disease conditions that may increase an individual's risk for severe COVID-19. Next slide, please. Persons with HIV, other immunocompromising conditions, or who take immunosuppressive medications or therapies may be at increased risk for severe COVID-19. Data are currently not available to establish vaccine safety or efficacy in these groups. However, these individuals may still receive COVID-19 vaccine if they have no contraindications to vaccination, but should be counseled about the unknown safety profile and effectiveness in immunocompromised populations, as well as the potential for reduced immune response and the need to continue to follow all current guidance to protect themselves against COVID-19. Next slide. Observational data demonstrate that while the absolute risk is low, pregnant women with COVID-19 have an increased risk of severe illness, including ICU admission, mechanical ventilation, and death. Additionally, there might be an increased risk of adverse pregnancy outcomes, such as preterm birth. There are few data on the safety of COVID-19 vaccine in pregnant women. Limited animal developmental and reproductive toxicity data are available, and studies in humans are ongoing or planned. If a woman is part of a group, such as healthcare personnel, who is recommended to receive COVID-19 vaccine and is pregnant, she may choose to be vaccinated. A discussion with her healthcare provider can help her make an informed decision. Next slide. Pregnant women and healthcare providers should consider the level of COVID-19 community transmission, personal risks for contracting COVID-19, the risks of COVID-19 to her and potential risks to the fetus, the efficacy of the vaccine, and the side effect of the vaccine and the lack of data about vaccine during pregnancy, during their decision making. Next slide. Next, I'd like to touch on contraindications and precautions. Next slide. CDC considers a history of the following to be a contraindication to vaccine with both the Pfizer and Moderna COVID-19 vaccines. Severe allergic reactions, such as anaphylaxis, after a prior dose of an mRNA vaccine or to any of its components. Immediate allergic reaction of any severity to previous doses of an mRNA vaccine or any of its components, including polyethylene glycol. Immediate allergic reactions of any severity to polysorbate due to the potential cross-reactive hypersensitivity with the vaccine ingredient polyethylene glycol. These patients should not receive COVID-19 vaccine at this time unless they have been evaluated by an allergist immunologist and it's determined that the person can safely receive the vaccine, such as under observation in a setting with advanced medical care capabilities.
Persons with an immediate allergic reaction to the first dose of an mRNA COVID-19 vaccine should not receive additional doses of either of the mRNA COVID-19 vaccines because the two vaccines contain ingredients in common. Next slide. As mentioned, persons with an immediate allergic reaction to the first dose of an mRNA COVID-19 vaccine should not receive additional doses of either of the mRNA vaccines. It's important for providers to determine whether the reaction reported following a vaccine is consistent with an immediate allergic reaction versus other types of reactions commonly observed with vaccinations, such as vasovagal reactions or post-vaccination side effects. This will help ensure that persons with a contraindication to vaccination don't receive the second dose, but not restrict those who are able to get their second dose from doing so. The following table of signs and symptoms is simply meant to serve as a resource, but may not be exhaustive, and patients may not have all the signs and symptoms. Providers should use their clinical judgment when assessing patients to determine the diagnosis and management. Next slide, please. CDC considers a history of any immediate allergic reaction to any other vaccine or injectable therapy, such as intramuscular, intravenous, or subcutaneous vaccinations or therapies not related to a component of an mRNA vaccine or polysorbate as a precaution, but not a contraindication to vaccination for both the Pfizer and Moderna vaccine. These persons should be counseled about the unknown risks of developing a severe allergic reaction and balance these risks against the benefits of vaccination. Deferral of vaccination and or consultation with an allergist immunologist may be considered until further information on the risk of anaphylaxis is available. Next slide. The following considerations can be used to help the provider conduct a risk assessment of mRNA COVID-19 vaccine in these individuals. The risk of exposure to SARS-CoV-2 because of residents such as in a congregate setting, risk of severe death, a disease or death due to COVID-19 because of age or underlying medical condition. And the ability of the patient to be vaccinated in a setting where appropriate medical care is immediately available for management of anaphylaxis. Next slide. Allergic reactions, including severe allergic reactions not related to vaccines, injectable therapies, components of mRNA COVID vaccines, such as polyethylene glycol or polysorbates, such as food, pet, venom, or environmental allergies, or allergies to oral medications are not a contraindication or precaution to vaccination. The vial stoppers, rubber, latex, and there's no contraindication or precaution to vaccination for persons with latex allergy. In addition, as the mRNA 19 vaccines don't contain egg or gelatin, persons with allergies to these substances do not have a contraindication or precaution to vaccination. Next slide. CDC recommends that vaccine providers observe all persons after vaccination. Those with a history of anaphylaxis due to any cause should be observed for 30 minutes. All other persons should be observed for at least 15 minutes after vaccination to monitor for the occurrence of immediate adverse reaction. Next slide. Finally, to put this all together, there are three categories of persons presenting for mRNA COVID-19 vaccines. Those that may proceed with vaccination are included in the green box. These are persons with a history of allergies that are unrelated to components of mRNA vaccines, other vaccines, or injectable therapies. Persons with these allergies who have a history of anaphylaxis due to any cause should be observed for 30 minutes. All other persons should be observed for 15. Persons with a history of any immediate allergic reaction to vaccines or injectable therapies, except those related to a component of the mRNA COVID-19 vaccine or polysorbate, have a precaution to vaccination, shown in the yellow box. A risk assessment should be conducted in these persons. Deferral of vaccination or referral to an allergist immunologist may be considered. If these people are vaccinated, they should be observed for 30 minutes. Finally, in the red box are those persons in whom vaccination is contraindicated. This includes persons with a history of severe allergic reaction after a prior dose of mRNA COVID-19 vaccine or any of its components, an immediate allergic reaction of any severity to a previous dose of mRNA COVID-19 vaccine or any of its components, or an immediate allergic reaction of any severity to polysorbate. These persons should not receive an mRNA COVID-19 vaccine at this time unless they have been evaluated by an allergy immunologist and it's determined that the person can safely receive the vaccine, for example, under observation or in a setting with advanced medical care capability. Next slide. In addition to what we've just discussed, CDC has developed tools that providers can use at the vaccination site to help identify persons with contraindications or precautions to vaccination, including a pre-vaccination form and further additional information in the form of a fact sheet. Next slide. And the key messages from these considerations are early recognition of anaphylaxis symptoms, prompt treatment with epinephrine, and activation of the emergency medical system. Next slide. COVID-19 vaccinations will likely be administered in a wide variety of clinical settings, including hospitals, long-term care facilities, outpatient medical offices, pharmacies, mass vaccination sites, and curbside or drive-through sites. These settings differ in terms of usual on-hand human and material resources to manage anaphylaxis. In the CDC guidance, we've included a list of medications and supplies that are important for evaluating and manage anaphylaxis and are recommended for those vaccination sites. And we've divided them into supplies that should be available at all sites as the minimum requirements to assess and manage anaphylaxis, as well as other medications and supplies that may be helpful to include where feasible. Next slide. Finally, the Clinical Immunization Safety Assessment, CISA COVID Vax Project, is an additional resource. Healthcare personnel or health departments in the United States can request a consultation for complex COVID-19 vaccine safety questions about an individual patient residing in the United States, not readily addressed by CDC guidance. Information on how to request consultation can be found at the link below. Next slide. Next, I'd like to review some of our safety monitoring systems. The overarching framework is the use of established systems to implement heightened safety monitoring for COVID-19 vaccines. In addition, CDC with other federal partners have developed new platforms and are leveraging other federal data sources to complement those existing systems. And three, we are communicating early and as clearly as possible on the vaccine safety process and systems now in place, and continue to provide COVID-19 vaccine safety data and monitoring results once available. For example, the MMWR that was just published today on the incidence of anaphylaxis associated with COVID-19 vaccines, the early data from some of our surveillance systems. Next slide. This cartoon simply seeks to kind of describe the large linked database monitoring systems that will be providing the safety data when vaccines become more and more widely available in the priority groups and in the general population. CDC's Vaccine Safety Data Link is a network of 9 integrated healthcare organizations across the United States that conduct active surveillance and research. And the system is also used to signal assessment to help determine whether adverse event signals are causally linked to vaccination. FDA has an extensive vaccine safety surveillance program that utilizes multiple systems. Medicare claims data are also used for active surveillance and safety-related research. CMS data includes data on over 90% of those 65 and older in the US, and has data on over 650,000 long-term care facility residents. Finally, the BEST and PRISM initiatives are large systems of electronic health records, administrative and claims-based data for active surveillance and research. Next slide, please. The Vaccine Adverse Event Reporting System, or VAERS, is a national early warning system to detect possible safety problems in US licensed vaccines. VAERS is also co-managed by the CDC and FDA and accepts and analyzes reports of adverse events and possible side effects following vaccination. It's not designed to detect if a vaccine caused an adverse event, but can identify unusual or unexpected patterns of reporting that might indicate a possible safety problem that requires closer investigation. Next slide, please. And VAERS accepts reports from anyone. Patients, parents, caregivers, and healthcare providers are encouraged to report adverse events after vaccination to VAERS, even if it's not clear that the vaccine caused the adverse event. In addition, healthcare providers are required to report certain adverse events after vaccination. Poison centers can report to VAERS as VAERS reports, as I said, reports from anyone. And our reviews of VAERS reports can help inform poison control centers, but the data are not shared from VAERS to the centers. Poison control centers are able to download general data from the VAERS website. Next slide. One of the main limitations of the VAERS data is that it can't determine if the vaccine caused the reported adverse event, as I'd mentioned. The limitation has caused confusion in the publicly available data from VAERS Wonder, specifically regarding the number of reported deaths. There have been instances where people have misinterpreted reports of death following vaccination as deaths caused by vaccine. And that's not accurate. VAERS accepts all reports of adverse health events following vaccine without judging whether the vaccination caused the adverse health event. Some reports to VAERS represent true vaccine reactions. Others are coincidental health events not related to the vaccination. And again, a causal relationship can't be established using information from VAERS reports alone, and simply serves as a prompt to conduct further investigation. Next slide, please. Healthcare providers are required to report to VAERS following adverse events after the COVID-19 vaccine and other adverse events, if later revised, whether or not associated with a causality. And serious adverse events per FDA are defined as death, a life-threatening AE, inpatient hospitalization or prolongation of existing hospitalization, a persistent or significant incapacity or ability to conduct normal life functions, a birth defect, or an important medical event that, based on appropriate judgment, may jeopardize an individual and may require medical or surgical intervention. In addition, cases of multi-system inflammatory syndrome, cases of COVID-19 that result in hospitalization or death are required reports. Healthcare providers are encouraged to report to VAERS any additional clinically significant AEs following vaccination, even if they're not sure if the vaccination caused the event. Also, report any additional select AEs or revised safety reporting requirements per the FDA's conditions of authorized use as specified under the emergency use authorization. Next slide, please. Finally, I just want to briefly talk about, in terms of safety monitoring, an active safety system. While VAERS is passive reporting, we encourage providers to help patients enroll into vSafe, an active safety monitoring system for COVID-19 vaccines, to stay updated on individuals' vaccination status. It's a confidential online tool that allows you to give health-related feedback after your COVID-19 vaccine. And it also reminds you when it's time to get your second dose. It's not an app, so you won't need to download anything to your phone. It uses text messages and short web-based surveys that allow you to tell CDC how you feel after getting. Someone from CDC may call back to check, individuals would receive a flyer after vaccine providing information with the vSafe registration link and a QR code allowing individuals to register. They can be used to participate in vSafe. And participation in these systems is incredibly helpful to CDC to monitor the safety of COVID-19 vaccine in real time. Next slide, please. During the first week following vaccine, vSafe sends a text message each day to ask how the vaccine once a week for up to 5 weeks. Questions vSafe asks take less than 5 minutes to answer. And when an individual needs their second dose, vSafe provides a new 6-week check-in process so individuals can share their second dose experience as well. There is additional check-ins at 3, 6, and 12 months after the final vaccine dose. Next slide, please. And this simply describes a little bit more about what vSafe is and asking healthcare providers to, if at all possible, encourage their patients to enroll in vSafe and review the information sheet that accompanies the vaccine. The CDC has also created an electronic version of that document, so you can read about it prior to administration of vaccine. Next slide. So I'll conclude by just saying that we all have a role to play in this immunization campaign. So public health partners with safety monitoring, such as the CDC, are promoting participation in vSafe, promoting reporting into VAERS, and communicating with partners such as you on issues regarding the vaccine, including efficacy and safety. And healthcare providers being able to participate in vSafe yourself when you get vaccinated, being able to describe your own experiences, encouraging our patients to participate, as well as reporting into the more passive systems such as VAERS, and being able to communicate clearly with your patients on vaccine safety and efficacy issues. Next slide. I'll conclude with these links for you to be able to learn more about the CDC COVID-19 tools and resources. Again, the COVID-19 landing page has a lot of information for both the lay public, public health practitioners, and healthcare professionals, as well as infection prevention control recommendations for evaluating individuals that may be coming in with febrile reactions after the vaccine when you're considering whether this is a post-vaccine reactogenic fever versus potential symptoms or signs of COVID-19 infection itself. This is particularly important for healthcare providers who may have been vaccinated or those residing in long-term care facilities, so that we're appropriately evaluating individuals who have fever and ensuring that that we take measures to decrease the potential risk of infecting individuals and further transmission of COVID-19. With that, I will stop, and I will turn the line back to the moderator.
Well, thank you very much, Dr. Pillai, for really an excellent and extraordinarily timely presentation. So many of our listeners, have wanted to receive this information, and you really brought it home, and from a position of authority as well. So thank you so much. I would also like to just make a note to those who are attending today that Dr. Pillai is actually broadcasting from Washington, D.C. So, many of you know that right now Washington is chaotic, and that may be some of the cause of some of the audio issues. So please excuse the audio. We're doing our best. So our next speaker actually comes from London, England, Dr. Dargan. I think we have pretty good audio with London right now, and he'll give a brief update about vaccine from the UK.
Thank you very much, Paul. I'm literally only going to talk for a minute or two in terms of the current situation in the UK. We've had a really significant surge in COVID cases in the UK in the last month to 6 weeks, and with an estimation that 2% of the UK population are positive. So the vaccine can't have come at a better time. We've had a huge increase in hospital admissions in the last month, exceeding the March-April peak, and we're starting to see an increase in deaths, and went into a national lockdown earlier this week. A lot of this has been driven by the new UK variant that many of you may have heard about. In the UK, about 8 to 10% of all COVID cases undergo genome sequencing to look at genetic mutations over time, and there have been dozens of mutations detected over the last year, not just in the UK, but in other areas of the world as well. The current variant of interest was discovered about 2 months ago, the B117 variant. It appears to be increasingly transmissible. The R rate is probably about 40 to 70% greater than the standard COVID strain. Although the preliminary clinical data suggests that disease severity is relatively similar in terms of hospital admission and case fatality. PCR testing, and importantly, the antigen-based lateral flow testing, appears to be unaffected. And there's uncertainty over vaccine effectiveness, but the general feeling is that it's likely that the vaccine will be as effective against at least the UK variant, although there is some question as to one of the South African variants in terms of vaccine effectiveness. In terms of where we are from a vaccine perspective in the UK, the Pfizer vaccine was licensed in the UK in early December, and vaccination started on the 8th of December. We also had licensing of the Oxford Astrazeneca vaccine a couple of weeks ago, and that is an adenovirus vector vaccine, so not an RNA vaccine like the Pfizer and Mrna vaccine. It's a vector vaccine, and vaccination started with that earlier this week. The advantage of that is that it doesn't require cold storage, and so community administration is likely to be much more effective. Mass vaccination is underway. About 1.5 million vaccinated so far, with a plan for 25% of the population to be vaccinated by mid-February, with a similar sort of priority list that Dr. Pillai presented for the US, with care home residents first, and then the elderly and healthcare professionals and those with comorbidities as the next layer and next target. The other thing I just wanted to briefly mention is that there's been a pragmatic decision by the UK regulator in the last week or two to prioritize the first dose so that to try and increase vaccination at a population level. So rather than everybody having dosing, first dose and second dose at 3 weeks, to prioritize the first dose and to look to try and get a longer dosing interval up to 8 to 12 weeks. To try and increase population cover. I mean, it's largely a pragmatic decision because the data is relatively limited, although the Oxford Astrazeneca study did actually look at different dosing intervals. And there was, in fact, a trend to greater efficacy with a dosing interval of 8 weeks compared to a dosing interval of 3 weeks. So potentially some limited data to support that. In the interest of time, I'll leave things there. But thank you very much for the opportunity just to give a brief update from the UK.
Very good. Then at this point, we maybe switch to the Q&A session. We have dozens and dozens of questions in the Q&A. Just want to give you all a heads up if we can stay another 15 minutes after 4 p.m. Eastern, so till 4:15 p.m. I hope it's okay with you, Dr. Pillai and Dr. Dargan. And with this, I'll turn it over to Dr. Dargan to start the Q&A.
Yeah, well, I mean, I echo what Paul said about Dr. Pillai's talk. It was fantastic, and I think the Q&A is a reflection of that as well. A huge number of questions. That there's a number of themes, and one of the things maybe we could start with is patients that have had COVID and had active treatment with remdesivir or convalescent plasma. Should that impact on when they receive vaccination?
The issue of remdesivir, no. But in terms of convalescent plasma, I don't want to misspeak. I believe there is guidance on that, and I would have to, we can take that back and confirm that.
Okay, great. Thank you. And maybe to some extent kind of linked to that, and do you know whether there are data to look at the efficacy of natural immunity versus vaccine-related immunity? And what are your thoughts in that regard?
That is, I think the bottom line there is we don't have enough data on that. It's area of ongoing investigation and interest. The rationale for continuing to offer vaccination to those that have previously had either symptomatic or asymptomatic infection is a acknowledgement that we don't understand the durability of vaccine. However, the earlier slide where I said it could potentially be deferred up to 90 days for individuals, kind of a nod to the fact that we believe that there is some durability for at least that 90-day period. But beyond that, I think we need more data, more time.
Okay, great, thank you. And then there were a few questions about kind of risk factors from a vaccination perspective. So some questions about pregnancy and lactation, about individuals with severe asthma or severe eczema, and specifically Guillain-Barré syndrome as well. I wonder whether that's something you could maybe just briefly touch on.
Again, one of the challenges is the immunization or the involved pregnancy or individuals that were known to be pregnant at the time of vaccine. So this is a area that, as I said during the presentation, is a shared decision making between the patient, the pregnant individual, and their provider. The issue of and what was the first question, sir?
Sorry, severe asthma, severe eczema, in terms of potential risk from an adverse reaction perspective.
Yeah. So, yeah, again, if there isn't that history of anaphylaxis to the components as I kind of outlined in the slides, it's not considered a contraindication as per the CDC guidance. I think if you the summary table, and I don't know if we can pull up the deck again. I think it's a helpful way of looking at it. Like, what are the absolute kind of contraindications? It's and then precautions, which you might consider a referral to an immunologist and conducting a risk assessment, is if there are immediate allergic reactions to vaccines or other injectable therapies, and that would be a precaution. But beyond that, we haven't delineated other absolute contraindications or precautions.
Okay. Thank you. There was a question in the Q&A, and I also wanted to ask as well about whether the US FDA are considering reviewing the Oxford AstraZeneca vaccine, and whether you think that may be a consideration within the US. Sorry, Dr. Pillai, you're breaking up again. Unfortunately, your audio.
So I don't want to speak on behalf. Operation Warp Speed has had multiple. Sorry, can you hear me? Hello. Hello.
Hello. Yeah, that's better. We can hear you again.
Okay. Yeah. So not wanting to speak on behalf of my FDA colleagues. All I would say is that the AZ vaccine is one of the products that Operation Warp Speed has been considering, and we eagerly await additional data from the ongoing trials, and look forward to working with our federal partners and international partners to see if and when a EUA submission will occur for that product as well. Over.
There were questions about what your thoughts were about a one-dose strategy versus a two-dose strategy. So whether you feel that there could be consideration of a one-dose strategy to try and increase the potential for population level administration versus the two-dose strategy for which the data is obviously available.
It's definitely I recognize that that's a question that has come up quite a bit, and I believe the UK has taken a position on that. Again, wanting to, and I will say that there are some vaccine, there's at least one vaccine product that is a one-dose vaccine series, but of the two products that currently have emergency use authorization, FDA released a statement, I believe it was on Monday, that reiterated that the US government FDA position is adhering to the conditions of use for the Pfizer and Moderna products, which is utilization of both doses. So the US government position right now is that is how these vaccines should be administered.
Okay, great. Another question I can just see has come up about sort of something a bit more technical. Is there any evidence of reverse transcriptase synthesizing complementary DNA from the mRNA in the vaccines? And if so, what are the clinical implications?
I will have to, I don't know the answer to that.
Okay.
That is a fascinating question, and I will have to decline because I don't know the answer to that.
Okay, great, thank you. Is weight a factor in dosing? There have been a couple of questions that have asked about weight and dosing from the perspective of obesity.
It's not a factor. It's where it is a factor is in the gauge of so this is more on the operational side of the house, but one of the things that Operation Warp Speed has done is also help develop ancillary kits to ensure that as we push out vaccine, we're also pushing out the needles and syringes that are required to administer vaccine, and based on body habitus and sex, there are tables, I believe, in the emergency use authorization documents themselves that talk about the appropriate needle length that need to be used for based on the size of the patient, but not necessarily the amount of vaccine that is administered for the.
Yeah, great, thank you. There were a question about can individuals after vaccination shed virus to others, and what data there are with regard to that from the published studies.
So the two authorized vaccine are mRNA vaccines against the spike protein. So there would not be any virus shedding.
Okay, great, thank you. So and then there were also questions that came up about.
Are you there, sir? Hello?
I wonder whether we lost Dr. Dargan. I think we kind of jinxed the connection in the UK. Dr. Pillai, I can maybe jump in and.
Kazi, just one thing. I think Dr. Dargan had asked one of the questions about antibody therapy before.
Yes.
And so I was just, while I was just quickly looking on the CDC documents. And so just the answer to that is there are currently no data on the safety and efficacy of mRNA vaccines in persons who receive the monoclonal or convalescent plasma as part of therapy. And based on the estimated half-lives of that, as well as the existing evidence on reinfection being uncommon in the 90 days after initial infection, vaccination should be deferred for at least 90 days as a precautionary measure until additional information is available to avoid interference of antibody treatment with vaccine-induced immune response.
Yeah, that makes a lot of sense. And one of our viewers also was asking if there's any reason why the Pfizer vaccine and the Moderna vaccine have different storage requirements, considering that they are very similar.
That's an interesting question. It has a lot of operational significance. I would have to defer to how the vaccines were manufactured, and so it would be a question that our colleagues at Pfizer and Moderna and BARDA would have to answer. I'm not sure what the nuances are of how the products were actually developed.
It makes sense. And, we've been, starting to see patients now in the emergency department that have received the vaccine, which is reassuring. They have some other complaints. I'm trying to make sure they're not related to the vaccine administration if it was recent. When you mentioned the history of allergy to to other injectable medications, and you referred to polysorbate and you referred to polyethylene glycol, would the CDC provide maybe a list of drugs that contain these diluents or solvents? I think that will be helpful, or does such a list exist so we can assess whether this history of allergic reaction applies here?
It's definitely something that we can take back because it's a great question. I'm sure most as a clinician or as a patient, it's difficult to kind of know what that necessarily means. I believe one of my policy colleagues is on, and it's definitely something we can take back to our clinical team and our communications colleagues.
Now, one of our viewers was asking, related to this, will FDA or CDC provide the data on the current adverse events or effects that are being, reported or suspected? Is there a way to view these data in near real time or shortly after they are compiled or assessed?
So I think one of the goals is to be able to transparently share information about what is potentially associated, or we don't, as I said earlier, know causality, but that's as an example, the MMWR that was just published 2 days ago, that within 2.5 weeks, information regarding potential associations with anaphylaxis were shared. And I think that's the underlying intent of systems such as VAERS to be able to, as well as vSafe, which is to rapidly collect information as best as possible and get that information out. And again, not wanting to speak on behalf of my colleagues at FDA, one of the goals is for them, like as part of the emergency use authorization, is to be able to get information about safety and be able to push that information back out to partners. And then the other source of kind of information is the vaccine safety data link, which is like a collaborative of multiple kind of academic medical centers to kind of, again, get information about potential safety issues and share that information quickly with the broader public. Over.
I agree. One of our viewers, Dr. Frank Walter from Arizona, was asking a couple of scientific questions that may require some consultation within CDC. But for example, the reverse transcriptase potentially synthesizing complementary DNA to the RNA, to the messenger RNA in these vaccines, and if that's something that's been looked at. And the other question also regarding other inactive ingredients other than the ones that you've mentioned, the polyethylene glycol. I know there are 2 or 3 other lipid nanoparticles. Are there any other ingredients that we should think about?
So again, it's a really good question. I think when you go to the emergency use authorization documents, not the letter of authorization, but the actual EUA material, it lists the ingredients within the vaccine. The ones that have been identified by CDC as potentially necessitating, precaution and contraindication were the ones that I referred to, like the PEG and polysorbate and prior anaphylaxis after potentially having received an mRNA vaccine. So those are the categories for the precaution and contraindications. The additional ingredients are located in the emergency use authorization. And again, I think it is a really good point, Kazi, to kind of go back and see if we can kind of, it may not be a comprehensive list, but examples at least of like what has PEG in it or polysorbate
right.
as an injection.
And also appeasing people's
oral formula.
And also try to do some risk communication about this question about becoming, a DNA or altering your DNA. That's very important for the public, I think.
And it is one of the, maybe I glossed over in my comments at the very outset of the presentation, but it doesn't enter the nucleus. It doesn't affect or interact with the person's DNA. But again, one of the things that CDC does is when they do get, questions, especially repeatedly, and there is, concerns, we build out our frequently asked questions section. So it's like, if this is something that, again, it may be something that we can take back and add to the body of existing FAQs.
Absolutely. I want to see if Dr. Wax has some questions in his queue. And I'm not sure if Dr. Dargan is back. So Dr. Wax, would you like to cover a few questions in your queue?
No, I think Dr. Dargan is back at this point. I think I'll turn it back over to Paul for that. Some of the remaining questions.
And yeah, guys, this Dr. Dargan, while you were away, I also looked up the question about Guillain-Barré just to make sure that I was tracking it. To date, no cases of GBS have been reported following vaccination among participants with, and this is again like as of today on the CDC website on the mRNA trials with Pfizer or Moderna. And with few exceptions, ACIP's general best practice guidance for immunization does not include history of GBS as a contraindication or precaution of vaccine. and the statement specifically is persons with a history of GBS may receive a mRNA COVID-19 vaccine unless they have a contraindication to vaccination. But as with anything, any occurrence of GBS following mRNA COVID-19 vaccination should be reported to the bears.
Great, thank you. That's really helpful. I'm not sure what questions were covered while I was out, but one of the things I was going to ask was about storage requirements for Pfizer and Moderna, and why there's such a great difference between the two, and whether there was whether anyone knows whether Pfizer are re-looking at their stability, and there may be the potential for change in that regard, because it has such a significant impact in terms of practical rollout.
So it did come up, and I know, but it's a really good question. And what I mentioned earlier was, as you said, there are operational impacts, and I would have to defer to our colleagues at BARDA or at the manufacturer itself at Pfizer for their plans for additional kind of stability assessments.
Right. There's one really good question that's just come into the chat about if a patient tests positive and symptomatic before the booster date, should that impact the timing of their booster, and should they still get the booster?
It's so going back to the it is a interesting question, and I'm sure that is one that is kind of increasingly, especially as we're having surge of cases. The main issues are, I think, the known current SARS-CoV-2 infection should be deferred until a person is recovered from acute illness, and you don't have to worry about potentially the vaccinator getting ill. And the recommendations apply to those that developed infection before receiving the vaccine doses, as well as those who may develop SARS-CoV-2 infection after the first dose, but before the second dose. And I think that's a scenario that you're alluding to.
Yeah.
And so, and there's no I don't think that there's a hard and fast rule about the minimum interval between that infection and vaccination. But I think if assuming that reinfection is uncommon in the first 3-month, 90-day period, if you do get SARS-CoV-2 infection in the preceding 90 days, it's probably, you can probably delay that second dose until, somewhere after the symptoms have resolved and they're out of there, but before that 90-day period. So hopefully that kind of gets at the question.
Great. And then maybe my final question, which is probably unanswerable in terms of the data, but it's probably one of the most important questions for us going forward in terms of, would you like to kind of postulate as to how long immunity may last after vaccination? Is this going to be the annual flu vaccine, the kind of 3-yearly vaccine? What are your thoughts? And I guess we don't have any direct data for that at the moment, but what are your thoughts in that regard?
Yeah, so I don't know. I think, we've heard from other leaders that it could be I believe Dr. Fauci may have said something to that effect in past, appearances, where it may be something that is part of our, routine vaccine schedule moving into the future. But I think we need more data. I think at this point, from an operational standpoint, we're still trying to get through those initial phases and get to the general public writ large. But it is something that I think people are thinking about. And I think in the coming months, we'll have more data on duration of immunity, reinfection risks, and I think that it's just going to be tincture of time before we have an answer to that question.
Great. Well, thank you ever so much for a fantastic talk. And I guess reflecting on where we are now compared to where we were a year ago in terms of active rollout of this vaccine and potentially something that could bring us through what we're all going throughout the world is it's amazing to see the science that's been achieved in this last year. So thank you for your overview and for dealing with the questions so efficiently as well.
Thank you for the opportunity to speak to you all, and I apologize for the audio difficulties throughout the hour, and I wish you all a happy new year and be safe.
Yeah,
Thank you, Dr.
yeah, thank you very much, Dr. Pillai and Dr. Dargan for the moderation and for the UK update. If we could go to the next slide. It was really an excellent presentation, and this presentation has been recorded and will be available on Friday, including the slide deck will be posted as well. We'll be continuing our weekly webinar series next Wednesday, January 30th. We're going to have a special talk on COVID-19, the neurological aspects and impact on stroke care. And we have two experts from Emory University who are going to be speaking both to the clinical effects as well as the pandemic's impact on otherwise routine stroke care and the consequences thereof. Next slide. Again, we have a webinar prospectus on our website. It takes you through all the past webinars and the upcoming webinars. Please feel free to take a look. And at this point, I will bid everyone adieu. Thank you very much and hope to see you again next Wednesday. Thank you.